Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
My name is Deanna Gomez-Hassan. I'm a neuroradiologist at the University of Michigan. The topic of my presentation is Epilepsy Imaging Tells a Story. I have no disclosures. The objective is to highlight the impact of imaging on patients with epilepsy. It is important to know the patient's history and know the clinical data to properly interpret the imaging. It is essential to develop expertise in sensitivity in identifying lesions that would help guide management. Background: epilepsy affects 1% of the population. Refractory epilepsy, also known as drug-resistant epilepsy, occurs in 20 to 40% of patients with epilepsy. These patients are considered for surgical evaluation, and to do so, imaging is essential in this workup. Here's a story. It's a 4-year-old who developed infantile spasms and refractory epilepsy at 2 months of age. On review by neuroradiologists who did not have the clinical information, the interpretation of this very high-quality coronal T1 view was that it was normal. When I was asked to re-review in light of the clinical information, my eyes were drawn to this region of the brain that showed blurring of the gray-white matter interface in this region, compared to the crisp gray-white distinction seen more peripherally in the brain. The quality of the imaging is very important. Additional sequences on the axial T2 flare and the coronal T2 also shows a region of hyperintense signal. It's subtle, but the gray-white distinction in terms of signal is not well seen here and here compared to the rest of the brain. Correlation with ictal-interictal subtraction SPECT, another imaging study, reveals an area of hyperperfusion in the left posterior quadrant corresponding to the same area seen on diagnostic imaging. This perfusion data is co-registered on the MRI. In light of the diagnostic data, a decision was made to pursue further surgical evaluation with a type of surgery called SEEG, selective electroencephalography. To do so, preoperative imaging is needed for surgical planning. This is a CT angiogram of the head needed to delineate the surface blood vessels. The abnormality is not well seen on this study. Here's a perioperative imaging study, CT, showing placement of those grids, or those electrodes. Here's also a post-grid MRI, also showing the position of the electrodes on this T2 flare sequence. Coronal T1 weighted images also show the position of these electrodes that are placed. And finally, the post-operative MRI shows the extent of surgical resection. It is important for the radiologist to ensure that all the abnormal tissue has been resected. So this is this patient's imaging story. There's the diagnostic imaging with additional data, preoperative imaging needed for surgical planning, perioperative imaging to show position and trajectory of electrodes, and postoperative imaging showing resection. Clinically, this patient is seizure-free. Epilepsy patients are considered for surgical management, and these patients are frequent flyers in radiology. Knowledge is a foundation. It is important for the neuroradiologist to ensure that diagnostic imaging is of the best quality and with the proper protocols. And to interpret these studies effectively, we need to have high sensitivity and experience to identify potential abnormalities, some of which are very subtle. We then have to correlate it with the clinical information. We often need to re-review the imaging once the clinical teams have provided all the data. This is an MRI on a patient who also with seizures, and the abnormality is shown here in the right hippocampus, where it's small and globular in appearance. In addition, though, the rest of the right hemisphere is also relatively atrophic compared to the left hemisphere. In the same patient on the axial T2 flare, you see these patchy areas of abnormal signal, suggestive of abnormal brain tissue beyond the temporal lobe. This is a different patient showing that also with seizures that shows an area of cortical malformation in the right parietal lobe. See, the gyral pattern is very abnormal, but there's no abnormal signal here. Patients often undergo robotic evaluation to further understand the network of epilepsy And this is the stereotactic device that neurosurgeons use. And this is an image showing placement of electrodes on a skull X-ray. Imaging and seizures are monitored through those electrodes. Then these patients are presented in a multidisciplinary conference with a number of different specialists to evaluate all the data. These patients are reviewed to consider all the imaging that is needed when they're being considered for further invasive monitoring using their robotic device. It is important to understand what the pathology is and what the surgical intervention needs to take place. Some of it is just for further evaluation using SEG, depth, or grids, and then there are post-treatment interventions such as LIT or DBS or corpus callosotomy in order to resect the abnormal tissue. SEG, selective electroencephalography, is often used now for patients with epilepsy. And it is essential, as I described previously, that you have the stealth MRI with contrast and a CT angiogram for the surgical planning. It is important that the radiologists review the protocols, ensure that it's the proper protocols, and coverage is appropriate for surgical planning, and we must report it accordingly. Here's a CT angiogram again of the head. Stealth MRI, this is a single slice showing the vessels on the surface of the brain, and both of these studies are inserted into the robotic device so that the surgeons can plan their trajectory. After the electrodes are placed, we get a grid, what we call a grid-focused CT and a grid-focused MRI, so that we can see the placement of those electrodes. So here's an example of a CT with electrodes placed. Not very diagnostic, but we need to make sure that there's no acute abnormalities going on in this region of the head. There's an MRI showing a patient also showing a number of different electrodes. Again, not very diagnostic, but we see the position of those electrodes. This abnormal region was present in this patient prior to grid placement. On that patient I showed earlier with a cortical malformation, this is a coronal T1 MRI showing electrodes after placement into that abnormal cortical malformation. This is the software that is used in radiology to identify and label each one of these electrodes. This is the view with the co-register MRI where we can identify each contact. In this patient, all the seizures were determined by the neurologist to be coming from the MA14 contact. The neurologist compares the imaging to the diagnostic imaging to ensure that the abnormality is covered with electrode placement. In this patient, no resection was performed since important functional activity was also identified in this region. This patient will pursue other potential options for management of their seizures. Let me share another patient's imaging story. This is a case of a 7-month-old with history of focal infantile spasms at 6 weeks of age, treated medically, who then developed refractory epilepsy at age 2. This patient had left temporal epilepsy by semiology and EEG. The diagnostic imaging was very subtle, but showed findings in the left temporal lobe. The left hippocampus was slightly smaller compared to the right. And slightly more posteriorly, there is an area of subtle blurring of the gray-white matter interface just lateral to the collateral sulcus, and shows hyperintense signal in the same region on the T2 flare. Decision was made to pursue SEG, and this is a CTA of the head for preoperative planning. Stealth MRI. This is a post-grid MRI showing the placement of the electrodes in the left temporal lobe, CT and MR. Initial postoperative imaging showed changes consistent with the left temporal lobectomy, as shown here and here. So this is the initial imaging story: the diagnostic imaging, preoperative imaging, perioperative imaging, and post-resection. But the story was not finished at this point. As you can see here, residual abnormality remained present in that left inferior temporal lobe in these two images. This is the resection of the left hippocampus. The surgeon knew that this abnormality was left, but it's important for the radiologist to know this too, that we just not only report postoperative findings, but there's residual abnormality. Additional surgical intervention was proposed. LIT is laser interstitial thermal therapy, which uses heat to target and ablate a specific region of the brain, and it uses stereotaxic guidance in order to reach the area in question. In this example, we see the trajectory of the probe that's inserted with the patient's head positioned prone, and you see the course of that probe, and finally the location of where the ablation was going to be performed. In the patient I was just sharing earlier, after the temporal lobectomy changes as shown here, this is the intraoperative MRI showing the position of the probe and the lesion within the posterior abnormal tissue. You can see it here on the sagittal views. 2 ablation approaches were used in this patient. Here is a view of the single probe in one of the ablation targets. A subsequent MRI used a routine brain protocol and revealed the changes from the initial surgery, and that's what it was reported. I sent the patient back for a dedicated protocol to show the following. So again, anteriorly, the defect from the left temporal lobectomy is seen on these images. Slightly more posteriorly, you see the defect in the hippocampus, but you see also this target site of the first ablation. Slightly posterior to that, you see a residual area of blurring and hyperintense signal, but even further back, here's the site of the second ablation, shown here and here. So on the sagittal views, you can see what was done. First is the initial temporal lobectomy defect, the site of the first ablation, the site of the second ablation. There is this region that remains present but is essentially disconnected from the rest of the brain, as this patient has remained seizure-free. In conclusion, epilepsy imaging tells a story. These patients are frequent flyers in the Department of Radiology. It's important to understand how the imaging contributes to the management of patients with refractory epilepsy. Imaging and management is drastically evolving, and we must remain current with new technology and surgical approaches and clinical data. Thank you very much.